Assalamu alaikum wa rahmatullahi wa barakatuh. Friends, colleagues, this is another second meeting, Emirates Cardiac Society with Emirates Neurological Society. My friend and colleague, Dr. Suhail Rukun, is the president of the Emirates Neurological Society with us and supporting, we both, I think both societies supporting each other to conduct, I think, very important things is fighting the stroke. And that last time we had atrial fibrillation, this time will be on hypertension. And we all agree that cardiovascular disease is the leading cause of death worldwide. And I think we reach like 19 million per year. And if you look, the risk factors contributing to this are many, but the major three are hypertension, which is today's topic, and dyslipidemia. So hypertension accounts for up to 50% of cardiovascular disease. So from cardiac point of view, about 50 or 49, maybe stroke is slightly higher. So we'll all be discussed tonight, inshallah, with our experts here. And I'd love Dr. Suhail also to give his message before we start the webinar. Dr. Suhail.
Shukran, Dr. Abdullah. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, our friends, colleagues. Thanks for this introduction, Abdullah. As usual, this nice platform and distinguished speaker always we will have. The most important message which we are giving tonight is how to prevent stroke by preventing the number one risk for any type of stroke. We have major two types of stroke that everyone knows about it, ischemic and hemorrhagic stroke. 70% of all admitted patients in our local series at Rashid Hospital, where we admit around 1,200 patients per year, 70% risk factor is in ischemic stroke, is hypertension. Hypertension is number one killer and causes of stroke and high mortality. If patients presented with high blood pressure, they will have a problem to receive the acute stroke treatment. Usually with severe high blood pressure above 200, these patients will have a higher mortality because of hemorrhagic transformation. What we notice in our series, Abdullah, also that 50% of these 70% stroke patients with high blood pressure, they are not recognized that they are having high blood pressure. So we have a huge number of community young patient who's walking around with high blood pressure and they are not diagnosed. So it's our pleasure to have our cardiologists, neurologists sitting today to discuss this is important topic which we can prevent, and it's a preventable disease. Abdullah, the mic is back to you.
Excellent. I know who's best to talk about this than Professor Suhail Rukun. He's leading actually and done great job. It's another time we'll talk about that. Tonight we'll go to the cardiology now. My friend and colleague Dr. Sharif Bakir, I think everyone in the field of cardiology know him. He's been everywhere in the UAE, so he knows every secret and every bit where to improve things. He will take us through the hypertension from cardiology point of view with case presentation. Dr. Sharif, we're looking forward to your talk.
Thank you, Dr. Abdullah. Let us to see, can you see my slides? Just 1 minute. Okay. You see my slides? Abdullah.
We're waiting, inshallah. It's coming, maybe it's coming. Have you?
You cannot see, or you can see slides?
Nothing yet.
No, I shared, just 1 minute. I shared the slide. It's supposed to be, you can see it now. Share.
Anyone else seeing it?
Share screen.
Yes, it's coming now, sir.
Yes. Now, yes.
Okay.
الخلفية البنفسجية. أيوه.
Okay, you can see. This is the first slide. You can see it. Okay. When I talk about hypertension, just we have to understand that hypertension is a silent disease. This is number one. And the most important is what is normal and what is abnormal blood pressure. This is also very important. If you look to the last few decades, that the guidelines have been changed many times, increasing and decreasing the normal range. Another important point is the treatment. When to treat and how to treat and why blood pressure control rate is still low. This is very important. Just I will start by this picture. This picture is 1945. This is the President Roosevelt in the Yalta meeting. During that time in 1945, he has 7 doctors with him, and everybody believed that high blood pressure is a very good compensatory mechanism. And everybody believed that high blood pressure is a protective. President Roosevelt died 4 months after this picture. Do you imagine what was his blood pressure during this meeting? His blood pressure was 250 millimeter mercury. And when he died, actually it was 270, not 50. If you look to the screen, you'd say 250, but it is 270. And when he died 4 months later, it was 370 millimeter mercury. And since 1937, his blood pressure was increasing. Why I am showing you this? To tell you that high blood pressure is a silent disease. It's called the silent killer. And what is the importance of that? Because the patient in all over the world, we have something called reaction behavior. Will not go to the doctor unless we feel something. If I am normal, I will not go to the doctor. Another important point, if someone have a headache and they went to the general practitioner and he measured his blood pressure, find it high, he told you that you have a headache because you have high blood pressure. This is totally wrong. Why? Because if the headache disappears after 2 to 3 days, the patient will stop his medication because he feels that his already blood pressure is controlled. This is a big problem. So what is hypertension? Is it number or is it disease? Or if you look to there, what any disease have symptoms. What is the symptoms of high blood pressure? It is silent killer. There is no symptoms. Etiology, there is no cause. Nobody knows what is the etiology of hypertension. It is multifactorial. I'm talking about the primary, the secondary, and the primary. We have to know that. So no clear etiology for primary hypertension. Lesion, what is it? Is a result from the disease. There is no clear lesion in hypertension. There is target organ damage, but no hypertensive per se lesion. So this is very important. And the dysfunction resulting from the lesion. So the problem is no clear dysfunction except target organ damage. So it is a risk factor. This is very important. We have to know that all the guidelines now, when they are dealing with high blood pressure, they put it in the context of the risk factor. So we have the disease and the risk. And based on that, the treatment will be decided. This is very important to put it in your mind. To understand the relation of high blood pressure to stroke or to ischemic heart disease. All of us, let us to take the coronary vessel, for example. All of us, our coronary vessel are patent, but the wall of our coronary vessel is full of cholesterol. So when the first year of your life, of anybody's life, there is no cholesterol deposit. After a few months, cholesterol deposit. This is 17 years old cholesterol deposit. This is in the coronary artery, in the cerebral artery, all over the body. We have to know that the length of our vessel is 120 to 140,000 kilometers inside our body. All of it lined by single cell layer. So for example, if somebody at the age of 30 to 39, 60% of the people at the age of 30 to 39, they have bad cholesterol in their vessel without symptoms, because there is no symptom for high cholesterol. And our vessels are lined by single cell layer. It's called the endothelial cell. So this is the cross section of all of us, our vessel. So what happened in the cerebral or in the vascular, in the heart? Suddenly the cholesterol, which we have it in our vessel, suddenly it will rupture. Once it's ruptured, it became rough surface. Within 1 minute, the platelets are idiot. They thought that this is outside injury. And within 1 minute, they do like this, clot, and they block the artery. If you remember the histology, this is a normal coronary artery. There is no lesion, nothing. But the plaque rupture, which happened here, leading to what we call the thrombus formation. The question we have to understand, when we're dealing with any disease in general, the number of risk and the time risk exposed. So what does it mean? The mortality and morbidity is related to how much time you are exposed to this risk factor. And for example, if I am hypertension since the age of 30, and now I'm age of 70, for example, or 40 or whatever. So the longer the time my vessel exposed to the risk, the more the morbidity and the mortality, which means that we have to treat the risk early. These 9 risk factors are the cause of plaque rupture: smoking, cholesterol, diabetes, stress, and the blood pressure, obesity, not eating vegetable and fruit, and also the physical activity, which is very important. So all this will lead to our risk will not be depending on this. So this is, I want you to look to this, very important. This is by Christian Bernard for the heart transplant surgeon. He said that I have saved the life of 150 people by heart transplant. If I had focused on the preventive medicine earlier, I might save 150 million. In the past, when somebody came to the clinic at 2013 guideline, European Society guideline, we said that will depend on the office blood pressure. But now 2018, this has been changed. You have not to depend on the office blood pressure. You have to depend on the home blood pressure and the ambulatory blood pressure. Why? Because according to the 2021 European Society of Hypertensive Practice guideline for office and out office blood pressure, we find that 25% of population, when they came to the clinic, blood pressure is high. When they go home, it is normal. Okay for that. But there is something called masked hypertension, which means 20% of the people who came to the clinic, their blood pressure will be normal, while when they go home, it will be abnormal. So we have to be very meticulous when we talk about the blood pressure. It is very important also to understand how to measure the blood pressure. This is very important. The patient should sit like this. And it is well known that you have, if you want to follow the guideline of European Society of Cardiology, Hypertensive Society 2021, you have before each visit, the patient have to do what is called 7-day blood pressure monitoring twice per day. This is a way to monitor, and you have to measure the blood pressure in the morning twice and in the evening twice. Patient have to sit alone for 5 minutes, put the cuff in his hand, not to do anything. This is based on the what is called the SPRINT trial. The SPRINT trial published 2015, and based on the SPRINT trial, the guidelines have been updated. So it is very important to measure the blood pressure right, and very important to do it in the correct way. According to the guideline, the blood pressure should be not more than 135 in the morning, not more than 120 in the night. This is very important. And the same, the European Society guideline 2018, the same. Let us to take this case, Mr. Mahmoud. Mr. Mahmoud is a 56 years old man, smoker, obese, dyslipidemic, not diabetic. His father have MI at the age of 45. No past medical history, no treatment. His blood pressure, Mr. Mahmoud, is 140. It is 140 and 7/82. So according to the guideline, Mr. Mahmoud is hypertensive. That also your combination of half dose calcium channel blocker, RAS beta blocker should be used. He does not take the treatment because he said, I don't feel anything. This is the common scenario for everybody. Or even if he take it to 1 or 2 months, we have to know that after 1 year, only 25% of the people who have been diagnosed as hypertensive, they continue on the medication. 75%, they stop their medication. Why? Because they do not feel anything. So Mr. Mahmoud is obese, smoker, hypertensive. He does not take his medication. So the guidelines have been changed. The American College of 2021. What they said you have to depend on the risk. Low risk people, you can start 3 to 6 months by lifestyle modification. But Mr. Mahmoud is not low risk. It is high risk, which means you have to start the medication immediately. And you have to be careful about what is called the masked hypertension. So we have to be careful when we decide Mr. Mahmoud is hypertensive or not. I want you to look to this equation. This is a 50 years of male. He have blood pressure is 120, but he's obese, body mass index high, smoker. So his risk for the next 4 years to develop problem, it is 8%. Why? Because his blood pressure is well controlled. Let us to increase the age of this person to make it 55. See, same blood pressure is well controlled, 120, but look to the risk. It is increased to 19%. If I change the blood pressure of the same person, same age, same everything, to be 147, look to his risk for the next 4 years, 73%. This is to tell you how much important is the high blood pressure in the context of the other risk factors. The association of age at the diagnosis of hypertensive with brain structure and also what is called the incidence of dementia. In this paper published very recently, 2021, they found that individuals with hypertension diagnosed at the age of 35 to 45 of age, the hazard to develop dementia or correspond to in the future is very high. So the more the blood pressure and the more the exposure to the high blood pressure, the more the likelihood of dementia. Interrelation between high blood pressure and organ damage and the cardiovascular disease. No more room for doubt. The conclusion, the prevalence of hypertension across the intervention guideline based on the different threshold find that it is a fact. So the brain MRI have been shown, the left ventricle have been shown, renal function, and low AB index. So this is to tell you how important is the hypertension. Salt and the hypertension, the current view is a little bit confused. Some people say that salt restriction is good. Some studies say that salt restriction is not in the equation, but everybody agreed that we have to reduce the salt intake. So conclusion, high salt intake is deleterious for the cardiovascular system, both in normal as well as in hypertension. Early but not late onset hypertension is related to midlife cognitive function. This is very important. The result of this study have been shown that our results expand previous evidence on early onset hypertension, begin an important independent risk factor for adverse event. And of course, the neurologists know this better than us. So to cut a long story short, as we said, the 147 is very high risk. Now we'll go to the treatment. We have to know that blood pressure regulation is depending on two very important mechanisms: sympathetic nervous system and the renin-angiotensin system. These are the key players for the high blood pressure. So hypertension is a complex mechanism depending on the cardiac output, depending on the total peripheral resistance, heart rate, stroke volume, arterial pressure, and venous pressure. And this is why now the guideline recommended the combined medication. Not only in the past, we usually take one medication and increase the dose. But all the trials have been shown, no, you have to start by multiple medication with a small dose. All the studies have been shown that if somebody is hypertensive, he will need at least 2 to 3 medications to be controlled. This paper published in the last European Society of Cardiology meeting, August, not this meeting, the meeting before, it's August 29, 2000, they done what is called quadruple ultra low dose tablet, and they found that it is very important. When you are treating the hypertension, you have to know that not one fits all. There is no one size fits all. You have different patients. Young patient with sympathetic overdrive, for example, different from old patient with renin-angiotensin system, patient with total body sodium, patient with renin-angiotensin system. So you have to tailor the treatment for every patient based on the age 6. Also, another important to know, drug don't work in patient who does not take them. So, which means that to control the same like Mr. Mahmoud. He didn't take, we prescribed him the medication, he didn't take the medication. 2 years later, Mr. Mahmoud developed non-ST elevation MI, stenting in the right coronary artery, but he still have preserved left ventricular ejection fraction. After that, Mr. Mahmoud stopped smoking cessation, start exercise, he lost weight. Now Mr. Mahmoud came after 4 years later. His blood pressure is 132/86 millimeter mercury. The question is this normal or abnormal for Mr. Mahmoud? Somebody will say, this is only 132, there is nothing. But as we said, we have to be very meticulous with the controlling of the blood pressure. You have coronary stent before, so we have to be very meticulous in the risk factor and in the treatment. Also, you have to know that what pulse wave reflection is very important. Young compliant arteries, the normal pulse wave velocity is 8 millimeter second, which means that this is the velocity and this is the reaction, which means with this velocity, peripheral amplification increase coronary blood flow. While this is we are talking about the diastole. while people with early stiff arteries with high blood pressure, they have increased pulse wave velocity, which means that the systolic is very high. So ventricular vascular mismatch, the reflected wave augmented aortic blood pressure in the late systole. So increased vascular afterload with propensity to develop left ventricular hypertrophy, decreased coronary perfusion, and increase also subendocardial oxygen consumption, increased endothelial dysfunction. So which means that all recognized by wide brachial artery pulse pressure. So you have to control the systolic blood pressure, because there was some confusion in the guideline of the American guideline, Joint National Committee 8. They said that people over 50, we can keep them blood pressure 160. But all this have been controlled and returned back again to have everybody to be 1/3. So if you go to the European Society or the American College guideline, we'll find that the 2013, they said below 140/90, and then 2015, after the sprint trial, they said 130/80, and then 2017, they changed. But why I'm showing you this, to say that American College and European Society guidelines are the same. There is no difference. Why? Because they put in the equation is the risk. To cut a long story short and to make everything simple, we want the blood pressure to be below 130/80 for all the ages, all the sex, and depending on the risk factor. So target organ damage is risk factor is part of the story. Whatever the age you are looking for, we are only have to make it simple, 130/80. And this is the threshold which we have to treat. And we have to know, to make it simple, 130/80, it is the guideline request. Take home message, I hope that you understand what I'm trying to say. Confirm a diagnosis by exclusion of white coat hypertension and secondary hypertension. Be aware about the masked hypertension. Provide lifestyle recommendation. This is very important. Verification of medication adherence is very crucial, because most of the patient, they stop the medication. Also, there is another important point, what is called inter-visit variation, which means some patient came to that visit, it is blood pressure is normal. After 3 months from visit, next visit, we find blood pressure is high. After another 3 months, we find blood pressure is normal. The inter-visit variation is also a risk factor. We have to keep our patient steady all the time. Appropriate use of type and dose of diuretic in the triple combination. Addition of first-line antihypertensive treatment, spironolactone or clonidine for the what is called resistant. Refer the patient to hypertensive excellence center. So before I came to give my lecture, I think he was confused. Now we became more confused. Thank you very much.
Thank you very much, Dr. Sharif. I think, this was great journey through and made it very simple. I mean, hypertension, normally we see 3-4 days on this topic, and or whatever you want to call it, risk factor or a disease. But, you learn that it's not only a risk factor, it could be subclinical problem, it could be a disease already established, and the complex of the management of the hypertension, of course, to prevent the events. So now we'll ask Dr. Suhail to introduce the neurology colleague, and then we'll take a talk later on, inshallah.
Thank you, Dr. Abdullah. Before we finish with Dr. Sharif, what you present tonight is amazing. This update in the guidelines, hypertension is not just stroke. Hypertension for neurology is vascular dementia, and you mentioned that micro bleed is one of the signs of hypertension. Ischemic stroke, subarachnoid hemorrhage, intracranial bleed, intraventricular bleed, intracranial stenosis, extracranial stenosis, carotid disease, hypertensive encephalopathy. So this is making the burden on neurologists to treat our patients more aggressive with their hypertensive medication. When I listened, Abdullah, to Sharif presentation, I was thinking 80% of the patients that I'm seeing, they are hypertensive. If the guidelines is saying 130/80, welcome to the club. It seems that the Cardiology Society need to do more awareness in the community, because there's a huge number who's above 130 and they're not taking any medication. So we will discuss this in our Q&A session. I would like to introduce my close friends and one of the distinguished neurologists at level of UAE, Dr. Ammar Al-Umar. Ammar is a neurologist from Ibrahim bin Hamad Abeidallah Hospital, Ras Al Khaimah. Ammar at the same time, he's the angel coordinator at the level of the region, and he's the first one in UAE who's there, his hospital stroke unit received the Angel Award. It's a distinguished certification for Center of Excellence, and Ammar is doing good job in Ras Al Khaimah to fight against stroke. Ammar, mic is yours, please.
Thank you, Dr. Suhail, for this magnificent introduction. Thank you for the organizer. Today I will talk about hypertension and stroke. I will share my screen.
Yes, we can see it.
So to continue the distinguished talk with Dr. Sharif, I will talk about the hypertension effect from the neurology point of view, which is the effect on the cerebral CNS and the stroke, in fact. So I have nothing to disclose. I will discuss the hypertension and stroke risk, management of hypertension and acute stroke, and secondary prevention. And lastly, we have some case scenarios. So stroke, as Dr. Suhail obviously talked about, this is not as in affecting the brain in several ways. So it can cause transient ischemic attack, ischemic stroke, hemorrhagic stroke, or vascular dementia also. It can cause by the effect on the blood vessels, the hypertension on the carotid arteries, the major large arteries or middle cerebral artery, causing a large infarct by doing the occlusions. Or it can cause this occlusion on the small arteries, as you see in the lacunar infarction, microinfarct, or leukorrheasis, which is the responsible for the silent deterioration of the cognitive function. And on the other hand, the hypertension might cause bleeding, and it will cause structural damage to the blood vessel, and that bleeding could be a microbleed, or it could be a macro with large intracerebral hemorrhage or intraventricular hemorrhages. So that's the effect of hypertension on the brain. And in regard for the stroke, hypertension is the single most important, most common treatable risk factor for stroke. As you see in this study, that the hypertension is by far is the most common associated comorbidity with acute stroke. And epidemiological studies on population studies and Chinese that shows that the prevalence of stroke, hypertension in stroke patients was 83%. And another systemic review of 32 studies by Mark Wilmont about high blood pressure in acute stroke subsequent outcome showed that high blood pressure in acute stroke is up to 75%. And uncontrolled hypertension is associated with poor outcome that is assessed by either by death or combined death and disability. Furthermore, the high diastolic blood pressure was associated with twofold rise in the recurrence, early recurrence of the acute stroke. In our hospital, Ibrahim bin Hamad Abeidallah Hospital, we have the calculations of the data that hypertension in 63% of the acute ischemic stroke. I think Dr. Suhail mentioned 70%, and this is in their hospital. This is slightly lower than the data we have in trial, but this is maybe because of the structure of the population in this area, because we have more younger age group and younger stroke patients. So We'll talk about the management of hypertension in stroke, and this is a little bit different because we have to keep in mind the management in the acute phase of stroke is a little bit different from chronic therapy or preventive therapy, whether it is primary or secondary. And there are different types of strokes that also may need different type of management. So we'll consider the transient ischemic attack, which is by definition, the patient will recover and there is no neurological deficit. They will be at their baseline, have no evidence of infarction by CT or MRI. So here there is no obvious tissue damage, and oral antihypertensive drug therapy should be initiated or resumed if the patient already on without further delay. We don't need to wait. But in ischemic stroke, here the patient with acute ischemic stroke, elevated blood pressure are typically tolerated during the first 24 to 48 hours. And why is that? Because it's augment the cerebral blood flow, so it reduces the expansion of the infarct core. Because you have an ischemic area, then the blood flow should be kept to maintain supply or oxygen supply to the brain tissue. In cerebral rate regulation, this is an inherited ability of the blood vessels to keep the blood flow constant or relatively constant. And it's a complex process with myogenic, biochemical process, but it means that when the blood pressure rises, the resistance of the circulation will increase to maintain the blood flow at a constant level. But in a case that is we are lowering the blood pressure abruptly, we may cause ischemia, as it's shown in the left side of the case. We'll keep that in mind, but there are exceptions. So the general rule in ischemic stroke that we keep the blood pressure on high level. But what is the exceptions that we need to interfere and give a treatment early is that if the patient have an extreme hypertension, which is more than 220 over 120 millimeter mercury, and if there is an acute hypertension but the related end organ damage, so patient who have an acute heart failure, and that the time we have to interfere and reduce the blood pressure. Patients who have active ischemic coronary disease, and we have some cases who presented with active acute ischemia, whether ischemia or non-ischemia, with an acute stroke, acute ischemic stroke. And patients also of having aortic dissection or women with eclampsia. And the special also with the patient with acute ischemic stroke who are candidate for reperfusion therapy, because we know that with the thrombolytic therapy, the incidence of hemorrhage increase more with high blood pressure. And the cut for this blood pressure is 185 over 110, and we need to go below that. How do we treat in an emergency hypertension? And we use intravenous medications. So intravenous labetalol, 10 to 20 milligram, followed by infusion, which is 2 to 8 milligram per minute according. Or winacardipine, 5 milligram per hour, IV titrated as needed, maximum 15 milligram per hour. Clofidipine, 1 to 2 milligram. I didn't use the clofidipine, we don't have, but if a blood pressure is not controlled or diastolic blood pressure is more than 140, consider sodium nitroprusside for effectively controlling or decreasing the blood pressure. What in acute ischemic stroke, what about above the beyond the acute phase? So after 24 to 48 hours, we can start or restart the antihypertensive, but keep in mind this is in a stable, more stable patient. Neurological deficit is stabilized, but in a patient who's deteriorating and there is progressive neurological deficit, we may consider a delay to maintain perfusion of the ischemic area. The question will be how much we lower the blood pressure. So we decrease the blood pressure after the 24-hour or 48 hours, but we should not be aggressive. And in general, the ischemic symptoms are found to be likely to occur, that is more ischemia over the ischemic stroke, if you reduce the blood pressure more than 25% below the baseline you have. And gradual reductions of pressure of approximately 10 to 15% per day or 24 hours is generally well tolerated. This is because why? Persistent hypertension leads to arteriolar thickening, and this in the cerebral blood vessels and other circulation may be in a part appropriate adaptation, so the arterioles will not transfer the high pressure to the capillary circulation and protect them from structural damage or bleeding. But what we'll have if we lower the blood pressure so abruptly, then the capillary circulation will be forbidden from that the hypertensive effect and the blood flow effect, and we induce more ischemia. And all our neurologists may experience that patients who deteriorate after the lowering blood pressure. What about if a case is a hemorrhage? Not an ischemic stroke, here it is intracerebral hemorrhage or intraventricular hemorrhage, which is usually the most common causes by the uncontrolled blood pressure and hypertension. So the data from the two largest trials, which is INTERACT-2 and ATTACH-2, that reached the recommendation that lowering of systolic blood pressure to a target range of 130 to 140 systolic is safe and may be reasonable in improving the functional outcome of the patients. And that will, in patients who presented with mild to moderate severity and blood pressure is above 150 to 220. So that initiation, the most important, we target a reduced blood pressure soon, not like the ischemic stroke, and it should be as soon as possible. The American Heart Association, American Stroke Association, they recommend with the guidelines to do it within 2 hours from the onset to start the antihypertensive treatment, lowering blood pressure. But what is the important about this? The blood pressure lowering, you should ensure continuous, smooth, and sustained control of blood pressure. No fluctuation. Avoid fluctuation because this might deteriorate the patients. Abrupt increase in the lowering blood pressure, then the blood pressure rises again. That was not make deteriorations. So please, what we need to ensure a smooth, sustained blood pressure lowering. They think that what about less than 130? If we lower blood pressure less than 130, it is harmful in patients with intracerebral hemorrhage, and we should be avoided. So we keep the blood pressure systolic more than 130, 130, 140, that will be optimal. With antihypertensive we use for after the acute phase, you know, that blood pressure should be treated, and this is for secondary prevention of the cardiovascular events, whether stroke or MI or other things. And these are more studies about progress study, PROFES, other studies, all in favor the analysis of intervention, giving a treatment to prevent recurrence of the stroke. So these meta-analysis of 35,000 patients prior stroke or TIA, the antihypertensive therapy reduced the rate of stroke from 8 to 8.7 versus 10, and cardiovascular death 4 versus 4.7%. But this large study, which is the PROGRESS, the PROPHES, and the PATS trial, which is studied the antihypertensive medications, they studied the AC inhibitors, ARBs, and diuretics. And they found that they are protective against recurrence of stroke and TIA. So many experts recommend AC inhibitors and diuretics for patients with a prior stroke or TIA. However, there are other meta-analyses of other studies, and in 2013, they studied the effect of calcium channel blockers for the prevention of stroke in adults with hypertension. And that involved more than 270,000 patients. And the effect of the calcium channel blocker were not statistically different from those of angiotensin inhibitors and diuretics. So we can use also that medications, and in addition, the combination medications, when combined antihypertensive medications, calcium channel blockers, plus the AC inhibitors is the ideal combination or the best combination for the patients. What we use, there is no preference we have regarding the brain, the stroke patients with the study. So I can use AC inhibitor, ARBs, calcium channel blockers, diuretics. All are reasonable for initial monotherapy. The one thing is the beta blocker. So there is some evidence that beta blocker used with hypertension don't prevent or reduce the stroke rate of recurrence. And then a beta blocker, it should be not used or unless there is another indication for it. The Black patients, older patients, and more than 60, or in the UK for than 55 years, they often respond better to thiazide and calcium channel blockers rather than the AC inhibitor. So in these particular patients, the favorable choice will be diuretics and calcium channel blockers. In, the HAASA 2021 guidelines for the prevention of stroke clearly demonstrate that that can be used, the different medications, and the different medications can be for different patients also. So different patients may have different comorbidities, and you may tailor your treatment according to their comorbidities also. And they also recommend the decrease, and the last one is the decrease the dietary sodium intake to control hypertension and to prevent secondary stroke. I want just to highlight some of the talk about, so in the form of cases. So this is a patient, he's 65 years old, male, hypertensive on amlodipine 5 milligram, and presented with acute ischemic stroke, which is onset of 2 hours. He's having right side weakness, 3/5, right facial weakness, and NIH score, a severity score of 6. So in this patient, the blood pressure was 200/105. So what we will consider for the blood pressure in such patient, in fact, this patient is a 2 hours duration if he have any contraindication for thrombolytic therapy, so he's a candidate for thrombolytic therapy. And in that case, we target a blood pressure to be less than 150, 85/110. And we can use labetalol as IV 10 to 20 or 20 milligram to reach that soon and to provide his thrombolytic therapy as soon as possible. While the same patient presented with acute stroke, but the onset is 10 hours. And the CT angio shows no large vessel occlusion. It's the same patient with the same blood pressure. Here, he's not candidate for thrombolytic therapy or reperfusion therapy. And in that case, what will happen to the blood pressure? So the blood pressure, we will start antihypertensive after 24 to 48 hours according to his condition, not immediately. And the same patient also comes with the right side weakness that's 2 hours ago, but it resolved completely within 15 minutes. And that the brain CT didn't show any ischemia or hemorrhage with the same blood pressure. So this is obviously, this is a transient ischemic attack that resolved. There is no structural damage, so we can start antihypertensive immediately. And in this patient, because the blood pressure is high and he's on single hypertensive, we may consider combination therapy with this high blood pressure to control the blood pressure, hypertension. And if you allow me, just also another scenario that this patient is presented with the hemorrhage. The CT scan showed hemorrhage, and this is blood pressure of 200 over 100.05. Here we should target a blood pressure to target systolic blood pressure 130 to 140, and we should start as soon. We don't wait for 24 hours. Okay, by this I will end my talk, and thank you very much for listening.
شكرا Dr. Ammar. جزاك الله خير. Very nice review. Very attentive message regarding the current guidelines for different comorbidity, and nice 4 cases that you present at the end. Jazakallah khair. We'll go to our next speaker, Dr. Abdullah.
No, I think we'll take questions and answers now, and then we'll go. So we have no questions from the attendees. We have 188 attending this, although registered 700. Great, but we want people to ask. I think the 2 talks were great. Let's go back to the origin of the problem. This is a risk factor, and as all of you, we agree, we kind of overlook things. We don't look sometimes the number. Sometimes we say, give excuses. Patient is being stressed, patient being driving, coming to. So there are many reasons. We try to not initiate. That's called inertia of the physician. Sometimes the patient tells you, doctor, maybe I'm not well today. Maybe I've been thinking, so doesn't want to be started on medication. So there are many things we need to confirm. And talk of Dr. Sharif, you talked about many things here about the importance of diagnosis. I think that's important because we are speaking about the chronic problem. Is for life. If you're going to diagnose somebody, let's do it properly, even invest in it, So whether that be an office, home, ambulatory, whatever. So just focus on that first before we go ahead, Dr. Sharif. How you, as a physician and a role model for us, I think here, and you diagnose hypertension, and in a fast life nowadays, things are very fast. How do you do it?
Let us, to be honest, go back to the NICE guideline. If you go back to the NICE guideline, they discovered that in the general practitioner, they found that many people have been diagnosed hypertension while they are not. And many people are hypertensive, but they are not diagnosed because of the masked hypertension. So what they said, before starting antihypertensive medication, it is advisable to do home blood pressure measurement and to do ambulatory blood pressure measurement. Why? Because once the patient is hypertensive, it is usually will be lifelong treatment. And as we know by age, it is a change. This is number one. So the most important is to be sure that this patient is hypertensive. And as you said, Dr. Abdullah, the patient usually have excuse because nobody wants to take medication. And especially you are taking medication for something you are not complaining of because accidentally discovered. So it is very, very important to convince the patient by let him to be shared in the story. How? By doing home blood pressure measurement twice per day for 7 days, for example, and to do ambulatory blood pressure, and then you let him to see the numbers by himself. So he'll be convinced that he's hypertensive and convinced that to continue on the antihypertensive medication. So, and also it is very important that we not depend only on the clinic visit, unless the patient have very high blood pressure without any doubt. But the patient borderline, I think it is better to do home blood pressure plus the ambulatory and then sit with the patient, give him time, because cholesterol, diabetes, hypertension, all these are asymptomatic disease. If you follow all the patients, you will find after 1 year, only 25% of the patient taking the medication.
I will stop here, Dr. Abdullah. Dr. Sharif, the last statement that you said that after following up these patients, only 25% of these patients are taking their medicine. Look, sir, Dr. Ammar and Suhail, we are seeing these patients every day coming with ischemic stroke or hemorrhagic stroke. Disabled young patients, 45% of the patients admitted to both center, Rashid and Ubaidullah, is younger than age of 50 with acute stroke, bedridden, ataxic, aphasic, and they're hypertensive. How can we increase the awareness and adherence of patients to their medication? And we'll go back again to Dr. Abdullah, Dr. Sharif, Dr. Hussein about the prevention. Lifestyle, cut down their salt intake, sedentary life, exercise. I think, Abdullah, if you will come with a new project as usual to come and to put it at the level of UAE, that would be something great. Sharif, how can we increase the awareness?
I think the most important, give time to your patient in the clinic. This is the problem. Usually the patient have no time in the clinic to explain to him, and no time in the clinic. Just will go, say, yeah, hypertension or not hypertension. Get my point? Patient need to know why he is taking the medication. Why we not to correlate between symptoms and the disease. This is the most important. And of course, awareness program outside to, this is another important point. And I think Dr. Abdullah Shab is pioneer in this. He can add more.
Thank you very much. I think what Dr. Suhail said, I think is crucial. I think, you know, unfortunately, we have only 1 hour for discussion of fighting the stroke. I mean, hypertension, we can sit and we can have a pathway for this. But just to be, the reason I ask you for diagnosis of hypertension, as you nicely said, we sometimes overdiagnose, sometimes underdiagnose. But I think in addition to the number, even what if you use home or ambulatory or whatever, we should not only look at the number, we should look at subclinical aspect of the hypertension. You know, there are new biomarkers available nowadays, and we as a cardiologist, we have access to the vascular to see if anything happened already. So we can convince the patient, because patient doesn't look at the number. You know, say numbers could be this and that and stress and so. So I think we have to come down and say, look, hypertension could be present to you as a marker now. Maybe you already have subclinical, maybe you have already some clinical symptoms or event. I mean, Doctor, today is all about events happening, but let us go back and do that. Dr. Hussein Hujmet, intervention cardiologist, you are a very aggressive man. Tell us, you have a question or comments, I think?
Yes, I have a question that I frequently get from the colleagues, and it's about managing acute blood pressure elevations in patients with ischemic stroke or with cerebral hemorrhage. And we have two expert neurologists, so I would turn the question to them. Which parenteral agents do you recommend for this situation? From my early medical school, we knew that nitroglycerin tends to elevate the intracranial pressure. So which agent should we count on?
Dr. Ammar?
Yes, we usually use the labetalol as a first line, but in patients who's having bradycardia or other contraindications, the nicardipine will be the next choice. But we don't use methyl dopa or hydralazine unless we have no access to these medications.
So yeah, Dr. Hussein, if a patient is coming with acute stroke to our hospital and their blood pressure is above 180, 185, systolic above 90, and he's a candidate for any intervention by alteplase or mechanical thrombectomy, labetalol of bolus 10, 10, 10 or 20, then to start infusion, that's normal practice. But from my practice, I notice if the patient, his blood pressure systolic is above 220, usually it will be very hard to get their blood pressure below 180 at the end. There's a questions to Dr. Ammar regarding the evidence of bringing blood pressure aggressively in the intracranial bleed. You know that patients with ICH, they will presented with acute headache or neurodeficit. CT will show there's a subcortical bleed or lobar bleed, and their blood pressure is 200, systolic over 100. How aggressive and safely will be able to bring their blood pressure down?
Yeah, so the recommendation is now to reach the systolic blood pressure 130 over 140. The idea was before that if we aggressively decrease the blood pressure, we might jeopardize the brain tissue with ischemia, and that is a patient with a hemorrhage. But these large trials that demonstrate the decreasing the blood pressure to this target is safe. And but the fluctuation is that may lead to deterioration of the neurological. So the recommendation now is to start as soon as possible lowering the blood pressure in intracerebral hemorrhage with blood pressure 200 between or 150 to 200 to target 130. We may use infusions, but you should maintain smooth, sustained blood pressure lowering.
Okay, and that's within the first 24 hours. You are speaking
Within
about
the first one. Yeah.
within 24 hours. Agree. Abdullah.
Yeah, let us go back to the, so we diagnosed the patient, Dr. Sharif and Dr. Ammar. We diagnosed the patient with hypertension because we attendees here mainly family medicine, and they want to know what to do next. So again, I want to convince the patient to start something, lifestyle, whether or the medication. What baseline investigation you will do? Again, to help you with where are you in terms of hypertension adverse already happened, or to help you with, to see, some you can prevent, or because sometimes hypertension, as you know, most of the time is combined with other things like diabetes, dyslipidemia, and others. So you want to really to have enough information to help you to choose the appropriate direction for the management, as well as convince the patient. So Dr. Sharif, what investigation you will do to help you for your management of hypertension?
Well, as we said, Dr. Abdullah, we are not treating number, as you said. The risk is part of the story. So I have to exclude all the risk factors, which mean I have to know that his renal function, how it looks like. I have to know his lipid profile, how it looks like. I have to know if thyroid function, how it looks like. So in the beginning, we are doing a lot of investigation. But for follow-up, another story. But you have to understand that the patient is not number, is a human being. This is very important. And if you look at all the risk, the guidelines, it is depending on the risk. And based on the risk, you will adjust your treatment. I hope I answer your question.
And on follow-up, what do you do on follow-up?
Usually, first we have to look at renal function is very important, because as you know, we are using treatment for ACE inhibitor, ARB, and affecting the kidney, and the blood pressure by itself affecting the kidney. Also, sometimes liver function we have to be careful about, because we are using statin for the dyslipidemia, and we have to understand if it is unlikely to have any liver affection, but just you can repeat it in case of you think that the statin have been used for a higher dose or something like that, but it's not the common. But for high blood pressure, what we all the time keen about the electrolyte, about the renal function, okay, and this is very important, and also the follow-up based on what is basic. And for sometimes, if you have patient thyroid dysfunction from the beginning, we have to follow. Yani, so we are not putting stampa for to follow, but we have to each individual. You have to tailor the treatment and the investigation for each individual.
I think one of the things, Dr. Suhail and Dr. Ammar and all of us, one of the things patient interested in is, it is, I mean, we are not surprised. We heard this many times. So how long do I continue with this medication? I've done, you say, doctor, I've reduced my weight. I'm following all whatever you told me. I'm better now. Can I downgrade or down titrate my medication? They don't like medication, as you know. Adherence is like less than 50% per year, in a year time. What do you do to up titrate or down titrate the medication for the patient, Dr. Sharif, Dr. Ammar? I mean, any of you guys.
Also, of the cases which is related to resistant hypertension in use of other drug, which is very common in UAE, which means non-steroid anti-inflammatory. This is very important. We have to keep in our mind. So this is very important, and the hazards of non-steroid on the kidney. So increase the blood pressure, affect the kidney. So this is also, we have to put it in our mind when we are dealing with the patient, because Dr. also we mentioned that inter-visit variability is very important. If you find the patient control this visit, next visit is not well controlled, this is very important to be keen about, because inter-visit variability, it is a risk factor by itself.
I just share with you my story today. I will come. I mean, just because you mentioned this, and I just saw a young guy came back from. He was on. تعرف أنت رايح البر حليوة. He says to me, Doctor, my blood pressure is very high. I say, okay, so you're taking your medication? He said, no, I stopped it for 5 days because he was away. So sometimes we don't ask this kind of question, patient taking the medication or not. We just jump to increase the medication. So please not to forget to ask about the patient taking the medication. Dr. Ammar, you want to say something?
For that, yeah, Dr. Abdullah, thank you. For down titration, unless the patient having readings of very low blood pressure, usually we don't down titrate. Even I will tell the patient that he said, my blood pressure is stable now, it's normal. Why I am still negative? I tell him this is the balance. Now you are balanced with the medicine. Don't lose this balance.
Dr. Hussein,
there are some situations actually where we can down titrate. One of them is related to a phenomenon, it's called regression to the mean. As blood pressure undergoes diurnal variation, it also has some variation over the days and the weeks. So we may see patients when they are at the peak of that variation, where they're having high blood pressure. And once we give them the medication, the effect of the medication and the natural regression to their mean, then their blood pressure goes down precipitously, which gives you a real idea about, it could be some also white coat effect. So my threshold would be if we go below 120. If we go below 120, then I may down titrate. Another situation is those individuals who are very methodic about lifestyle modification, because we know that weight loss, physical exercise, DASH diet, salt restriction, every one of these lifestyle modifications can cut between 3 and 7 millimeters mercury, and they add up. So in those ideal patients who really strive for lifestyle modification, we can cut on the dose sometimes.
Super, and this is what we see, Dr. Hussein, in our daily practice with our stroke patients. Subhanallah, الإنسان ما ينعدلش إلا بعقاب. So these patients, when they will have a minor stroke and they will start to take their medication, within 3 months, their blood pressure is well controlled, they are doing good, they will stop smoking, they will start to do some physical activity, their wife will take care of them, they are eating healthy food, and within 6 months after starting 3 different mechanisms of hypertensive medication, we will find that they only need to be on one type, Dr. Abdullah. And this is so common in these good patients who will do life modification, as Dr. Hussein said, and they will come later down with their medication if they change their life. And the most important, as Dr. Sharif said in his last slide, and be sure that they are taking their medication. Shukran.
So in this last 5 minutes remaining, let's focus now on medication. I mean, everyone speaks about, this medication, that medication. The experts, have different opinion, but the whole matter is really controlling the blood pressure. I think that factor should be agreed on. The second thing I think is important, you want to also start patient on medication that has got least, adverse, the side effects, and patient able to take it for life. If you think that hypertension is going, so you don't want to give a medication which got that and that kind of side effects, as you all know. So combination of this medication, and I just want to hear from you guys, you are expert, without names, but I'm saying just combination as a mechanism. Which one, Dr. Sharif? Dr.
Can I say something very important, Dr. Abdul? For example, if someone is known to have enlarged prostate, okay, and is going to the bathroom 2-3 times per day, of course, when I'm trying to use diuretic, I will think many times, because if I give diuretic, the patient will go to bathroom more frequently at night. If I have to give diuretic, I will tell him just take it in the morning. Get the point. So we have to tailor the treatment based on the patient need and based on side effects that you expect from. Somebody have bronchial asthma or something like that, ACE inhibitor, of course, unlikely to cause for him a cough, but it can. And sometimes you will be a mix between this is related to asthma or related to the side effect of bradykinin with ACE inhibitor or something. So you have to look for everything from different angles. It's not just one, you write the medication and that's all. Also beta blocker. Beta blocker for me, it is good, not bad. Especially if you have high heart rate, because we like the hypertensive to have heart rate below 80. So it is not just fixed, but you have to tailor the treatment for every patient.
Yeah. Anyone got any other? Yes. So in addition to high blood pressure medication, of course, you want to prevent a stroke now. Okay. You want to prevent. I'm not. We talk about the after. So anything else you will add? Other medication like antiplatelets, antilipids for these patients? Dr. Ammar, Dr. Hussein,
Ammar,
Sharif.
According to the risk factor, it's a risk assessment. How much is the cardiovascular risk? That will maybe we start dyslipidemia treatment. If he's having an event, we will start antiplatelet. But just for hypertension, we will not start them.
Excellent. I like to hear that from the neurologist, because
as you know, also always we will calculate CHAD score in these patients. Hypertension is one of the additive factor for the anticoagulation in AFib patient. So if it's there also, that will be considered. Also, it depends on the subtype of the stroke. Is it ischemic stroke? Is it hemorrhagic stroke? What type of hemorrhagic stroke to know what to add on these patients? So definitely cardiology always on board in these patients who's coming with an acute stroke, that they will be controlling their blood pressure in my institute. Yes.
So if I ask the neurologist here now, we cardiology hypertension is, it's very disabling, of course, when they have the stroke. Anything else you ask us to do in terms of as a cardiologist, following this webinar, you mentioned some of the horrific numbers data here in the UAE, but we don't see the stroke that much. We see myocardial infarction, we see all that. But so from cardiology treating hypertension, anything you advise us, or the family medicine? Both of you, Ammar and Dr. Suhail.
Yeah, the prevention is better than treatment. That's prevention of stroke. So controlling the risk factor. I remember when I studied neurology in the 90s, the first cause of dementia was vascular dementia, and number one, not Alzheimer's disease, because of the risk factors. But once controlling the risk factor in the Western area, that's Alzheimer's become the more common. So things are more if you are going to the lower level, so not waiting the patient to come to the office. We may have a screen in their workplace for blood pressure and requiring treatment for that. May screen when they have a residency. It's an important for the community to mention, and we see, and Dr. Suhail and others, very bad hypertension in the Far Asian population. And they have very drastic complications also from stroke or other cardiovascular events.
From the population study, Dr. Abdullah, we know that low blood pressure means that it's below 120 systolic.
Right.
Healthy brain till age of 90. Dementia is less if your blood pressure is below 120. Independent for your life quality, daily activity by blood pressure below 120, you will be, when you are reaching certain ages, elderly or seniority, you will be independent. So guys, control blood pressure, come down with your salt intake, do a few things about your life modification. This will control your blood pressure. For the family doctor, you are the front line. Dr. Suhail, Dr. Ammar, we are not seeing these patients except when we see them in our emergency. And when the emergency has happened, طبق كل حاجة. المريض, we lost his brain, is disabled, we will start to rehab him. But please, family doctor, you have the major burden to prevent these stroke to come to our hospital.
Excellent, outstanding. I think I will come back to you, Dr. Hashim, because we are for the CME accredited event. I think time is done now. Sharif, you want to say something before we go to our sponsored meeting? Voice. ما نسمع صوتك.
I think everything has been covered, but also that the most important point is the patient have time. You have to have time with your patient to explain for him the hazards of high blood pressure, and don't wait for the symptoms. This is the most important point, because as we said, 25% of the patient will continue after 1 year, 75% will stop their medication.
Right. Dr. Hussein, want to say something?
Yes, because speaking here to the colleagues in general practice, there are two very common risk factors for hypertension and maybe resistant hypertension that we can oversee. Number one, sleep apnea. So I'm trying now to keep the questionnaire, the stop bank and the other questionnaires in the waiting area so that the patients can look at them and they take what's happening. And I'm really finding 1 out of every 4 or 5 patients has some features suggestive of sleep apnea, and if we treat that, hypertension can be improved. The second thing is serum potassium. Finding a borderline serum, low serum potassium or low serum potassium should really the red flag for hyperaldosteronism. It's common and it's associated with more target organ damage, and it can be easily treated with one of the MRAs. So potassium and sleep apnea.
Great. So we'll now move to, thank you very much. I think it was a great, 1 hour on education. Now we'll move to, this is a sponsored education, of course, by the two societies, and the sponsor will be by Saja, and our speaker here, Dr. Hussein Hishmat, is well known in the field of intervention cardiology, highly education person, and he will take us through how can we fight the stroke using this molecular olmesartan and hypertension. Dr. Hussein Hishmat.
Thank you, Dr. Abdullah, for the introduction, and thanks for the invitation. I'm glad to speak after my colleagues and the experts. These are my disclosures. So I'll be talking about olmesartan as a molecule, How does it compare with other RAS blockers? Does it have any effects beyond blood pressure reduction, and the efficacy on the combination? But before I start, probably the most important slide is that I would like to tell our colleagues, if we're looking forward to preventing stroke and myocardial infarction and heart failure and atrial fibrillation, then the most cost-effective method is by controlling blood pressure. And it's so rewarding to the extent that if we reduce the mean blood pressure just by 2 millimeters mercury, we will reduce stroke mortality by 10%. So for 2%, we get 10% reduction in stroke, 7% reduction in ischemic heart disease. This is for the systolic blood pressure. So whenever you're having a hypertensive patient and you're lowering his blood pressure, you're doing a great job and a great service to the patient and to the community. The same applies to the diastolic blood pressure. 2 millimeters reduction in diastolic blood pressure will reduce the risk of coronary disease by 6% and the risk of stroke by 15%. This is a huge number. If we look at statins, they don't give us the same potency. If we look at blood sugar medications, they don't give us the same effect. And when it comes to cost, the hypertensive medications are way cheaper compared to statins and newer diabetes medications, and of course antiplatelets. So if you want, as a physician, to give your patient a good service, then control his blood pressure. So now we'll be talking about, in the coming 20 minutes, I'll be talking about olmesartan. It's one of my favorite ARBs. It's a prodrug. It comes in olmesartan midoxomil. It's metabolized in the GIT immediately to the active form, which is olmesartan. It does not need cytochrome and the interactions of cytochrome, so there are almost no drug-drug interaction. Once it was given oral, it reaches the peak effect within 1 to 3 hours. The half-life is 18 hours. 40% is excreted renal, 60% is excreted in the hepatic form. And to your information, this is not a new molecule. This has been around for more than 20 years. It's one of the early ARBs that came to be used. So how does this molecule with these features compare to other ARBs that we have currently available? I'll go with you through some studies that compared the efficacy and the safety of olmesartan versus other ARBs. Before we go into that, again, I have preference to ARBs in general for one big reason, is their tolerability. As we've seen and we've discussed with the previous colleagues, when patients think that they will be committed to a lifelong therapy, they think of convenience and they think of side effects. And what distinguishes ARBs among other classes of antihypertensives is their safety profile when it comes to side effects. So how does olmesartan compare to losartan, valsartan, and irbesartan? This was a study, as you see, back in more than 20 years, conducted in the United States, involving more than 580 patients. And in all the hypertension studies, there is a washout period. The aim of the washout period, that the patients stop any previous medications that they are taking. We make sure that they will not go into that phenomenon of regression to the mean where the blood pressure normalizes. In this study, they recruited patients with a diastolic blood pressure of more than a cuff measurement more than 100 or average daytime measurement more than 90. And they randomized them into one of the 4 ARBs, and the starting dose. The starting dose of losartan is 50, valsartan is 80, irbesartan is 150, olmesartan is 20, and they looked at 2 weeks and 4 weeks and 8 weeks, how did the blood pressure behave. And as you see from the curves, olmesartan in white was significantly better compared to other ARBs in terms of reducing the diastolic blood pressure with an average of 11.5 millimeters mercury. This is in the cuff blood pressure. Looking at the average blood pressure, diastolic and systolic, you see also a significant reduction of diastolic and systolic average blood pressure with olmesartan compared to the other angiotensin receptor blockers. And looking at safety, the safety and the side effect profile is the same among the 4 ARBs. One point to consider is the trough to peak ratio, which is how much is the effect sustainable. And this differs among different ARBs. And looking at the systolic trough to peak ratio, and this will have reflection on the 24-hour coverage, you see that olmesartan has probably one of the highest trough to peak ratio among the antihypertensives. It means that at the start of therapy, after the patient takes the pill, in 3 hours this will be the peak, and before the next dose it will be the trough. So the ratio is like 70%, which means that roughly 69% of the effect will be maintained throughout the 24 hours. Looking at the diastolic pressure trough to peak ratio, again it's close to 70% in olmesartan and losartan. So why are we talking about peak to trough effects? Because many events, for some reason, of strokes, myocardial infarction, sudden death, they tend to occur in the early hours of the morning because it could be related to the cortisol surge. So there is an urgent need to keep the blood pressure controlled, not only in the morning hours while we're walking and we're under stress, but also in the night time, where we expect the surge of catecholamine and cortisol, which can cause the events. So for every 1 millimeter mercury increase in this critical timing, there is a 3.3% increase in the risk of cardiovascular events. So we need to make sure that the antihypertensive that we are giving will be able to cover this critical hours of the early morning. So this is a study of 24 hours ambulatory blood pressure, again comparing olmesartan, losartan, valsartan and irbesartan. And looking at the change in systolic blood pressure of olmesartan versus losartan, systolic and diastolic. This is the time of ingestion of the medication, which is 1 hour. You see that the peak effect starts in 3 hours. And looking again at the end, which is before the next dose, we still see a significant separation between olmesartan and losartan, roughly 3 millimeters mercury in the critical timing where we exactly need them. The same phenomenon is seen with olmesartan versus valsartan, with even more. The difference is even more, because valsartan may have a short half-life that can be a point of weakness for valsartan, which is not seen in olmesartan. With irbesartan versus olmesartan, we see the same phenomenon. Olmesartan has an extra advantage in the last few hours before the next dose, which are critical hours. So how does olmesartan, we've seen compared to the 3 ARBs, how does it compare to candesartan, again assessed by 24 hours ambulatory blood pressure? These again 44 centers in Europe, 643 patients with moderate hypertension, and you see the effect again, which is sustained. Olmesartan gives an extra 4 millimeters mercury diastolic blood pressure and roughly 2 or 3 millimeters mercury systolic blood pressure, and the difference is maintained throughout the 24 hours until the time of the next dose. Again, this doesn't come with any meaningful side effect difference. So we've seen how this molecule behaves in terms of blood pressure reduction in comparison to other ARBs that we currently have. So does it have any effects beyond blood pressure reduction, looking at metabolic parameters, inflammatory parameters, or vascular parameters? This molecule is originally Japanese, so you'll find some trials in Japan. So looking at a Japanese group of patients who have type 2 diabetes and hypertension, they compared olmesartan and telmisartan, not only on blood pressure, but also on a wide battery of metabolic parameters. And this was a crossover study. Patients were on valsartan, so they were controlled, and then they were either randomized to olmesartan versus telmisartan for 8 weeks, 2 months, and then they shifted from telmisartan to olmesartan and vice versa. And they used to take blood samples every 8 weeks. And the blood samples were hemoglobin A1C, fasting blood sugar, insulin resistance, and other sophisticated inflammatory parameters, interleukin 8, interleukin 6, high sensitivity C-reactive protein, and adiponectin. We see the same effect. Olmesartan has a significantly better ability to reduce systolic blood pressure and diastolic blood pressure and the mean blood pressure. You see the p-values are significant in the 3 parameters. And comparing olmesartan and telmisartan, which is a good angiotensin receptor blocker, you see that olmesartan in the last few lines, in the last few hours of the day, still maintains a 3 mm mercury advantage in systolic blood pressure and a 3 mm mercury advantage in diastolic blood pressure in the critical times of strokes and MIs. Looking at biochemical parameters, we see an advantage of olmesartan over telmisartan when it comes to high sensitivity C-reactive protein. And high sensitivity C-reactive protein is one of the risk enhancers. We use that in patients with moderate risk for atherosclerotic events. If it's elevated more than 3, then it tends to shift the patient to a higher risk category. And olmesartan was able to reduce high sensitivity C-reactive protein compared to telmisartan, able to reduce interleukin 6 again compared to telmisartan, and this can reflect on cardiovascular events. So we've seen metabolic effects. Does it have effects on the vascular structure in the cerebral circulation or in the coronary circulation? One of the important studies is the MORE study, the multi-center olmesartan regression evaluation study. This looked at carotid intima media thickness and plaque volume in the carotid. The carotid artery is one of my favorite arteries. That was my MD thesis back in 2005. It's an accessible artery. We can see it with a 10 megahertz transducer. So you can examine the intima, which is very hard to see in other arteries. So we can measure the intima and we can measure the plaque. This trial randomized 165 patients who had blood pressure between 140 and 180. They were randomized to olmesartan 20/40 or atenolol. And they did ultrasound for 2 years. They did the ultrasound at baseline, at 28 weeks, 6 months, then 1 year, then 2 years. And they looked at the intima media thickness and the amount of plaque in the carotid bulb. And the carotid bulb, because turbulence of flow, is the site where most of the atherosclerotic plaques tend to develop. And the study found that despite comparable blood pressure reduction, olmesartan had a better reduction in the plaque volume compared to atenolol. So it seems that this molecule, again with some other ARBs also, has some anti-atherosclerotic effect when we examine that effect on the carotid artery. And it seems it's not only on the carotid, it looks like a general anti-atherosclerotic effect. This is one of the famous studies. It's done in 2010. It's called OLIVUS. And this is very pertinent to interventions like me and Dr. Abdullah. Why? Because it looked at patients with stable coronary disease who were doing PCI and they had hypertension. And their PCI, they did the culprit vessel, which had the critical narrowing, but they also examined other vessels and they did IVUS, intravascular ultrasound, intracoronary ultrasound, and they did follow-up ultrasound in patients who were on olmesartan and patients who were on control. They followed up the intravascular ultrasound at 12 to 16 months. Intravascular ultrasound takes cut sections in the coronary artery and then reconstructs it in a longitudinal format. And from intravascular ultrasound, we can see the lumina of the vessel, and we can see the adventitia of the vessel. And between the lumen and the adventitia, if we see any thickening, then this is plaque. And we can measure the plaque volume, and we can measure it again, so we get an understanding of, is atherosclerosis in this patient progressing, so the plaques are getting bigger, or it's regressing. And patients here were randomized to olmesartan versus control. They were taking aspirin, statins, some of them were diabetic, taking oral hypoglycemic agents, etc. The study found that there was no meaningful difference in blood pressure. The aim here was not the blood pressure. The aim was looking at the plaque. Does olmesartan have an anti-atherosclerotic effect as we've seen in the carotid? And the answer is yes. If we look at the change in the plaque volume, we find that there is a significant difference with olmesartan compared to the control group. And surprisingly, this was not replicated in the trials of ACE inhibitors. There's a study on, again, a similar study that compared perindopril and control, and there was some non-statistically significant effect with perindopril. So these trials may give some assurance that ARBs have also anti-atherosclerotic effect similar to that we've seen with ACE inhibitors. So we've discussed the molecule itself, olmesartan. So how does it perform when we combine that with amlodipine? So I'll be talking first about combination and why they are important. And I never get bored of repeating this, the rule of 10. What does that mean? It means that most antihypertensive agents are good. They give a meaningful reduction in blood pressure. But when we start by half the dose, whether it's a thiazide, it's a beta blocker, it's a RAS blocker, or a calcium antagonist, you see the white column, we get roughly 7 millimeters mercury, maybe 5. So if we double the dose, we will not get double the reduction of blood pressure. We just get a small increment in blood pressure reduction. And if we give further doubling of the dose, we still don't see doubling of the blood pressure lowering effect. We see an extra 30 or 40%. So what does that mean? It means that if we give the patient an antihypertensive and it's not controlled, the way to go is not by doubling the dose. So instead of doubling amlodipine from 5 to 10, which will not give you excessive double lowering, instead of doubling the dose, add another class. Because if you add the other class, then you will get an extra 7 or 8 millimeters of mercury. Whereas if you double, you will get only extra 2 or 3 or 4 millimeters mercury. This is one of the reasons why now the European Society of Cardiology and the American guidelines and the International Society of Hypertension, they all recommend single pill combination when we're starting with a blood pressure of 160 or more. Why is that? Because number one, it minimizes the physician's inertia. You give the patient one pill instead of giving 2 pills. So the burden, the mental burden on the physician is better. And for the patient, it means better compliance, more adherence. It means better safety and lower side effects, because as we double the doses, then we increase the chances of getting more side effects, the edema of amlodipine, erectile dysfunction, dehydration of diuretics, nightmares of beta blockers. So instead of going to the higher dose and getting the side effect, keep the average dose and add synergism by another agent. And we've seen this across the board. When we give the patient the same identical medications but in free combination, we give the patient amlodipine and olmesartan as free combination versus we give it as one pill. What happens? The high level of adherence is way more with a fixed dose combination. The low levels of adherence is much less with a single pill combination. And this, of course, will reflect on faster blood pressure control and achieving the targets. And this is the magnitude of reduction that we get not only with a dual combination, but with a triple combination. We can achieve blood pressure reductions of huge magnitude. And the side effects will be less. One of the disturbing side effects of calcium antagonists is the lower limb swelling, because these are predominantly arteriolar dilators. They do not affect the veins. Whereas ARBs, olmesartan here, also dilates the veins. So there will be a tendency for the peripheral edema and the extravasation to be less. And the combination of olmesartan and amlodipine has been studied. It has been there for more than 15 years now, and the record has been perfect. So I chose only a couple of studies for the sake of time, which is the COACH study combining olmesartan and amlodipine. And this is a huge study, included more than 1,200 patients, and they were randomized into different classes. Olmesartan different doses, amlodipine different doses, and then different combinations so that we understand which combination would give us the best blood pressure reduction. And there's no surprise that as we combine olmesartan in an increasing dose with amlodipine, the 40/5 or the 20/10 or the 40/10, they tend to give us way higher levels of patients achieving the goals, because they can reduce the systolic blood pressure, and the systolic blood pressure, of course, better than single pills. And in the same trial, it was demonstrated that the chances of peripheral edema were reduced by more than 54% because of the mechanism that we just described. Another study on central blood pressure, and we can discuss and we can dedicate a whole talk on the central aortic pressure. This study compared olmesartan amlodipine versus perindopril amlodipine on the central blood pressure. The central blood pressure in the ascending aorta and the aortic arch is different from the blood pressure which is measured in the periphery, in the brachial artery or in the popliteal artery. Because as the wave, the contraction of the heart, ejects a wave, and this wave is transmitted across the vasculature, it gets augmented. So there is a difference between the pressure in the aorta and the pressure in the brachial artery. The pressure in the aorta tends to be lower than the pressure in the brachial artery, but this is the pressure that is transmitted directly to the brain and is more reflective of the risk of stroke. So in this trial, they compared olmesartan amlodipine with perindopril amlodipine on the central blood pressure and the peripheral blood pressure. And these patients were high risk. All the patients who were recruited by the criteria, they needed to have at least 3 cardiovascular risk factors, and their blood pressure was uncontrolled. This was a big study, 480 patients, and they were randomized parallel into olmesartan amlodipine, and then they can increase to hydrochlorothiazide, or perindopril amlodipine 10/10, and then can be increased with addition of hydrochlorothiazide. And you see that across the different parameters, systolic blood pressure, ambulatory, daytime, nighttime, it was all in favor of olmesartan amlodipine 40/10 versus 10/10. And the patients who were normalized based on any criteria were way higher with olmesartan versus perindopril. And more interestingly, that the reduction in the central blood pressure was again better with olmesartan versus perindopril, with no difference in side effects. So to conclude, we have a molecule that is effective and safe, with efficacy that can be better than other available ARBs. The data on inflammation and atherosclerosis regression are there and solid. combination is effective and can be more potent compared to other RAS inhibitors. Thank you so much.
Thank you very much. And I think that we reached almost the end of our program. So I don't know if you tried this combination. I've actually until what 2019 I kind of resistant to using olmesartan. I don't know why, because of Japanese, I'm not sure, but the reason I don't use it. But then once I started, the combination of olmesartan with amlodipine being really is my kind of said prevailed my favorite to the patient and to the, because long acting, as you said, and it's really well tolerated by everyone. The only problem I had once or two patients, they were complaining of some allergies they get. I'm not sure if you guys, some kind of allergy they feel, happen to their skin. I had to refer some of them to the dermatologist, but they said, we don't know the reason for it. I mean, have you come across anything like that? No.
Honestly,
Right. Maybe I use a lot of them, that's why. Right. So I think we reached the end, and this was a great meeting, Dr. Suhail. Your society, Emerald Cardiac Society, really doing a great job together to fighting the stroke. We started with atrial fibrillation, today was hypertension. So we learn how to diagnose, how to convince the patient and the physicians through the lifestyle, through the choosing the right medication, and when the event happened like a stroke, how to manage this with the expert we had, both Dr. Ammar and Dr. Suhail, and of course the input from Dr. Hussein Hishmet, Dr. Sharif. Great talk. So, and thank we thank also the Saja for this sponsoring this event. Of course, would that be possible without their sponsorship? And of course, the ICOM for great management. Dr. Sharif, you want to say something?
The price of the olmesartan is the cheapest one compared to all other ARB. I am right or wrong?
You are absolutely right, because people ask normally about the brand. The people like brand.
Yeah, because
most of the other ARBs become like generic, but it's the only brand which is the cheapest now available. Yeah,
I face it with many patients, especially when their demand is now start to be finished. I think they told me that it's the cheapest one, which is very good.
So thank you very much, guys. God bless you.
Dr. Ammar, Dr. Abdullah, Dr. Sharif, Dr. Hussein. It's a pleasure to see you on the Zoom meeting, and next month wait for the third webinar with the cardiology and neurologist, brain and heart together, always.
Thank you. Assalamu alaikum.
Thank you.